Welcome. My name is Dr. Holly Hampe. I am the Program Director for the Health Administration Program at Robert Morris, and we are thrilled to have you here tonight. We're going to be talking about emergency management and disaster preparedness. Mark Ross has a great presentation for us. Before we get started, though, just want to again welcome you. I want to do some introductions. Dr. Jillian Harrington is in the front row. She's one of our full-time faculty. Dr. Diane Ferndeck is next to her as a full-time faculty. Tanya Ulrich is one of our adjunct faculty. Vicki Bernowski is in the back. She's one of our adjuncts. A.J. Harper is in the middle there. He's also an adjunct. Bill Wentling is our department head, and he's in the back. And so we all would like to thank you for coming. We are videoing tonight so that we can share it with our online students. As you may or may not be aware, we have an undergraduate and graduate program at Robert Morris that is Health Service Administration, and we have an online and on-ground for our undergraduates as well as an online for our graduates. So, and we've got some graduates in the graduate students in the audience. If you'd stand up, we got stand up. There we go. Yay. And I know Dr. Byers is in the back, and she's always faithful about bringing students from her nuclear medicine classes, and thank you very much. And Dr. Luann Richardson is here. She's always a faithful follower from our nursing program. The Department of Health Sciences has health administration as well as nuclear medicine, and we are in the School of Nursing and Health Sciences. And it is a great combination of nursing, health administration, and nuclear medicine. I'd like to have Dr. Jillian Harrington come up, and she's going to explain our Honor Society and give you a little bit of information and the students that would be being inducted into the society.
Hi everyone, thank you, Dr. Hampe. Just wanted to share a little bit of information. If you had seen our original invitation, you may have seen that we were holding an induction here tonight from 6 to 6:15. Unfortunately, the folks that are being inducted this spring are not able to be here, so we're having a faux induction, I guess, but sharing their names and a bit of information. But I did want to tell you a little bit about the organization, just so you have that background knowledge if for our other students that may be interested in striving to become part of this organization, or for our professionals in the crowd may be interested in hiring some of our graduates. When you see Upsilon Phi Delta on their resume, you'll know what that means. So the organization is Upsilon Phi Delta, as I just mentioned, and it is a national health administration honor society. So it's not just here at RMU. We are a chapter, but it is a national group sponsored through AUPHA, which is our certifying body for our undergraduate program. So this is an undergraduate only, unfortunately. Sorry to the grad students in the crowd, but this is just for our undergrads. And the folks that are honored in this group have received a 3.5 GPA and have reached a certain level in the program. You have to have 15 credits in your health administration classes to be invited. So we have, every year we invite, for the past 2 years we've invited, we just started this last year, I'm their faculty advisor, and we invite any student that meets the criteria. And this year we did have 4 students that accepted the invitation to be inducted. Megan Bernchich, Lauren Kelly, Maddie Martinez, and Heather Pankari. So we're very excited that they're going to be joining us. The group, they actually receive, I brought a little bit of the paraphernalia they get. Everyone will get a lovely certificate that gives the information about AUPHA and Upsilon Phi Delta. They'll get a pin that they can wear on their regalia or any time that they would like. And then at graduation, they'll also get a red and blue honor cord, which will indicate their membership in Upsilon Phi Delta. I did just want to share a little bit of info about the organization. The mission statement, and we do have a national mission statement, and it is to recognize, reward, and encourage academic excellence in the study of health administration. So it really does represent not just a general honor society for their very hard work, but also very specific to health administration, and can be a great honor to be in the group, and also a lovely piece of jewelry for your resume per se, to put on that resume and make it just that much better. So students in the group, please strive to reach that level of GPA, and we'd love to welcome you to the group next spring. So a round of applause for our new inductees. So thanks so much. I'm sure that you'll be seeing me again next spring, and hopefully we'll be able to have students. The bulk of the students that are currently being inducted are online students, so they're unfortunately not necessarily close to campus, or they do most work during the day. However, probably next term we'll start to see our on-ground students being inducted. So hopefully we'll have a robust class for spring 2020. So thanks so much.
Now, Dr. Harrington mentioned about AUPHA, which is our undergraduate certification certificate. We just recently received that last year, that certifies our undergraduate program that we met the standards similar to a joint commission in a hospital setting. We're in the process of getting our graduate program accredited by CAMI, which is a national organization, and it is, again, similar to a joint commission where you have to address standards and meet what they're looking for, and it takes a program to the next level. And it also, I've said this and it ages me, it is a good housekeeping seal of approval, and I've said that to some students and they're like, I have no idea what you're talking about. And it's like a Rolodex. They have no idea what a Rolodex is either. So it is definitely, we are continuing to strive to make the program better. Our program, undergraduate 120 credits, our graduate is 42 credits. Both of the programs require internships, and many of the internships have led into positions, as Brittany would attest to, one of our students that got a position during her internship. We do have 2 advisory board members, and I want to recognize them tonight too. Gary Chase, we have 3 advisory boards here. Gary Chase is one of our advisory board. Lisa Parizo is our alumni and also an advisory board member. And we've got Lynn Watson, who is also an advisory board member. And we are just very fortunate with the program to have such professionals that are looking out for the program, are telling us how we are doing. Maureen is also our student representative, as well as Andrew Burke is our student representative on our advisory board, and hopefully we can keep those. And it's our opportunity to really get a pulse check of what's going on in the industry and have people that are in the industry, students that are in the program, that have been in the program, and that can tell us how we're doing, how we can do things differently. So we're always looking to make things better. But without further ado, I'm going to get into the program. And tonight we're going to be talking about healthcare emergency preparedness, the requirements, the best practices, and lessons learned. And Mark Ross is here from HAP, and he'll give you his bio whenever he comes up. But I do want to say thank you to AJ and Healthcare Council of Western Pennsylvania for sponsoring tonight's event and bringing Mark in. And AJ has always been my partner in crime in doing these programs, and I really appreciate his help. And what the program will be, Mark will be speaking till 7, and then we have an esteemed panel getting up, and we'll do those introductions at that time. And then the panel discussion will go to about 20 to 8, and then from 20 to 8 to 8 o'clock, we'll open it up to questions from the audience. So hopefully you think of some good questions. I'm sure Mark and the panelists are going to be ready for a good conversation, and the the purpose of tonight is to network and to be educated. And so we've got our networking, we'll have education, and yes, after the program, we are available also to speak about the program or things in it. Jen Young, are you still here? She's from Institutional Advancement. She was here, so maybe she's left. But we've got a number of people in the audience that are from Robert Morris if you have any questions about it. So I'm going to have Mark come up, and Mark Ross from HAP. There you go. Take this down.
Thank you very much. Thank you, Holly. AJ, thank you. I'm a walkie-talkie, so bear with me, okay? I can't get stuck behind a podium. Before I get started, I have to introduce my deputy director from the Hospital Association of Pennsylvania, who is assigned to this region and helps run our program. That's Jason Brown from HAP, who's right over here. And Jason's going to add some color commentary for me and cover a section that I'm pretty bad at. As Holly said, I'm from the Hospital Association of Pennsylvania. I'm the Vice President of Emergency Preparedness. What we do is we facilitate, administrate, and operationalize what's called healthcare coalitions. Where did this come from? It's something we've actually been doing for a number of years, but I always like to start my slides with this quote from Ben Franklin. Give you a little bit of my background. I spent 18 years in a very large healthcare system outside of Philadelphia as their emergency manager and did some risk management. I've got a total of over 25 years. I know that's hard when I look 29. The only one that laughed was here. So you all bought it. But I like this. Fire, a little bit of law enforcement. My whole life has been preparedness and response. So by failing to prepare, you're preparing to fail. And I think some of our past events in this country, and I'm going to go back to Katrina when we start, demonstrate some of that. And unfortunately, sometimes we're repeating our same mistakes. So how do we make that better? There's a lot of regulations out there. I'll start by telling you that I am a contractor to the Pennsylvania Department of Health. I am under contract with them, as is Jason and the rest of our team. Pennsylvania DOH has regulations for hospitals and healthcare over emergency preparedness and life safety. CMS has regulations. Joint Commission has regulations for emergency preparedness, as does CARF and all those other accrediting bodies. So it's important, okay? We're going to touch on a little bit, and I'm not going to bore you with a regulation lecture. We're going to get into real-world best practices and lessons learned so that when you get out into the field, you can help us make a change and continue the change that I hope we are starting. So right after Katrina, and for those of you that don't know, we lost a lot of people in healthcare during Katrina. A lot of people under our care didn't make it. There's a book, if you have not read it as a healthcare person, 5 Days at Memorial. Please get the book and read it. We talk in healthcare a little bit about crisis standards of care and what we would do if there was a reduced care that we could give. That book tells it in very strong words about what happens when we have to make those decisions. So after Katrina, CMS decided to look at emergency preparedness and how they could make it better. I think the first drafts, Jim, you were around at that point, I think the first drafts we probably saw were sometime around 2008 when the first draft started circulating to us. The rule didn't go into effect until November of 2016. That's how long it takes to get some of these passed. Now, they are currently doing rewrites on the CMS rule. How long before we see the rewrites? Who knows? It could be a long time. But what this whole idea was to bring the rest of healthcare up to what they thought the hospitals and the acute care standard was. how the hospitals and acute cares were truly functioning at a preparedness level. So there were 5 core elements to the rule. The first one involves the emergency plan, policies and procedures, communication plan, training and testing of your program. It doesn't mean that you need a binder on your shelf that you can go look at. It means you need an entire program. How do we train staff, new staff, re-educate staff each year on what to do in an emergency? You need that program element. And then obviously emergency power systems. And we're still learning on this one, and we'll get into a little bit of Hurricane Irma. We still haven't learned that lesson completely. The emergency plan, and I'm going to reiterate this, and again, I'm not going to go line by line because I think the most important thing for you is those real-world events. You must have an emergency preparedness plan. It's got to be reviewed annually. It's got to be based on what your risks are. So if you're in Nebraska, you don't have to worry about a tidal wave. Okay? Why are you writing plans for it? It's got to be based on what the risk at your facilities or your area is. Incident response guides, functional annexes. What do we do if there's a mass casualty event in our region? What happens if there's that mass shooting that takes place? How are we going to surge? How are we going to take care of those people? What's going to happen if we lose water for 5 days? You need that utility plan. So those are those annexes that it's requiring. Talking about your resident population, do you have special needs in your community? Healthcare, we serve special needs. So we need to address those in our plans. The whole thing that you're going to see in CMS, and this is where I believe CMS failed, when the first drafts came out, they mentioned healthcare coalitions. Now let me backtrack a little bit, and we'll get into it when we get to ASPR. But healthcare coalitions is a term that came about under federal regulations from a funding source in 2012. Our team is actually funded through that grant called the Hospital Preparedness Program. In 2012, the federal government required states to name healthcare coalitions. Does anybody know what a healthcare coalition, you guys can't answer. Does anybody know what a healthcare coalition is? I'm looking at the students. Anybody know what a coalition is? Okay, we know that a coalition's a group that gets together, right? A healthcare coalition in preparedness is everybody in the community. It's the public health agencies, it's the hospitals, it's the ambulatory surgery centers, it's the dialysis centers, it's that whole of community in healthcare, along with emergency management, EMS, all getting together before an event so that we know each other, so that we're planning together, so that we're training together, so we're exercising together. Pennsylvania is very fortunate, and I'll look to my Western brethren that are here. Philadelphia, Pittsburgh, Harrisburg area, we were coalitions before coalitions was an appropriate term or an acceptable term. We were talking. We were very fortunate in this state that we're ahead of them. But throughout the CMS regulations, it talks about collaboration with local government, with healthcare, with public health, to make sure that we're working together, that they understand what we're going to do in an emergency, and we understand what they can provide or what they're going to do during an emergency. And when they first wrote it, it said, must be involved with your healthcare coalition. That language changed 45 days before they printed it and said, now, local preparedness efforts, local partners. We were a little upset that the coalition term came out, but it still gets to the point that you got to be involved. So now anybody that accepts Medicare and Medicaid for healthcare should be involved in a healthcare coalition. We still have some that aren't. All the acute cares are. We're getting the others. But that's crucial that everybody understands what the plans are. Policies and procedures, again, communication plans are the key. the first thing that is always cited in every exercise or event that you ever go to, what can we work on? Communications. We're humans, we talk, but we don't talk real well sometimes during events. That is a number one. So their communications plan has to be updated annually. All those policies and procedures that go along with it, and again, we're going to move through. But the bottom one here, a system to track the location and staff and residents in the facility during and after an emergency. One thing that happened during Katrina was we moved people and we couldn't account for them. So now federal funds are tied to the fact that if you have an emergency at your facility, you have to account for your staff and your patients. That could be a plan that simply says, I need something in paper. In this state, we're very lucky. We have a program that'll help us do that, but you've got to be able to account for everybody. And when we get into some of the stuff, I'm going to tell you about a 250-bed hospital in Florida that had 1,300 people and almost 90 pets in it during Hurricane Irma. They accounted for every single person and every single four-legged friend, okay? That's a requirement now. More of this. Do hospitals close? Hospitals close? I had a counterpart in South Carolina, Paul. Paul was a hospital CEO before he moved over to the State Hospital Association, and his hospital was right on the coastline. And he used to say that during emergencies, the hospital was the guiding light, the lighthouse that the community came to. That's what healthcare is in this day and age to all the people that we serve. We're not only the right place at the right time for the right patient, we are during emergencies the beacon that they know they can come to and get care. That's what these come after as well. The fourth bullet point there talks about arrangements with other facilities. So you know the hurricane's coming, you need to move your residents, you need to have agreements with other facilities to take it. Again, very lucky in the state of Pennsylvania, we have what's called a statewide mutual aid agreement that says, for those signers, that in the event of emergency, Holly's facility will take my patients and we'll work out the details later, okay? Or if I need something from the facility, we'll share it, or we'll share staff. Now that's put into the regulations. You must have this. 1135 waivers deal with being able to get paid when you need to move your facility to an alternate care site. That's the big thing behind that. Again, the communications plan, who you call, when you call, information to receive the state. It also involves the contractor. What happens when the heat doesn't work at 2:30 in the morning? What's the number that you call? That's all in your communications plan as well. So these are all necessary requirements now. Other facilities that you would contact, physicians, so on and so forth. Before, nursing homes, that their regulations weren't as stiff. Hospitals that always had Joint Commission, we had regulations under Joint Commission or requirements where we had to do exercises. Nursing homes never had that. Now under CMS, they not only have a requirement for one, but they have to do 2 exercises a year with their community partners, and that means the Healthcare Coalition. This has been a big plus on bringing them into the preparedness efforts because if Jason was speaking right now, he'll tell you, we can tell when facilities are up for their inspections from CMS because all of a sudden the phone will ring and they'll go, yeah, we have the inspectors here and we have to have an exercise done in the next 30 days. When we're done breathing or giggling a little bit behind the phone because we know they just walked in the door, then we worry about, okay, how do we get you involved? So there is a requirement. They have to do these. Real world events do count, and they must document them. There's this other little requirement out there that says facilities must be what's called ICS and NIMS compliant. ICS, in preparedness, we speak in acronyms too, all right? ICS is Incident Command System. NIMS is the National Incident Management System. So ICS is the language we speak. NIMS is the framework that we work under in that language. So they have to document in NIMS compliant documentation. We help them with that as well. All right, this is the power, and I'm not going to get into the NFPA requirements, but what it says is if you have a generator, you have to test it. You have to have fuel. If you don't have that, then you have to have a plan for what happens if the power goes out. Those requirements hit, and we'll get into some that happened. Hurricane Irma, when it hit Florida, 24 days later, the Florida legislation passed sweeping regulations for healthcare that required generators in all nursing homes within 90 days of the enaction of the law. Jim, could AHN, if you didn't have generators, even pull that off in 90 days? It's next to impossible what they did, but they took CMS, they took it back to the original draft and basically upped it and forced it. Florida is really struggling with trying to comply to some of those regulations. These are regulations that we see hitting other parts. Texas has a very similar law after Harvey hit. There's talk in other states about similar laws that take CMS to the next level. So there's requirements for that. I handed Jason a microphone because I'm going to talk about coalitions in general, but since we are here in southwestern PA, and are you all from here? You all from southwest PA? Most of you? If you can't tell by my accent, I'm from the eastern side of the state. Okay. This is Jason's region. I kept the slides in for southwestern PA's healthcare coalition. One thing, when I say coalitions are great, they have all this. Pennsylvania has 9 healthcare coalitions. There's states that have 20. There's states that may only have 1. There are, across the country, Jason, help me, 400 coalitions? 492, thank you. 29 in my mind's going. So there's well over 400 healthcare coalitions across the country. Are they all the same? Not one of them. When you've seen one healthcare coalition, you've seen one healthcare coalition. They function differently, dependent upon their membership, depending upon, like me, who speaks a little louder. They change, and the needs of the community. So we kept Southwest in here, but again, let me go back to that regulation that follows the grant funding. Pennsylvania receives about $8 million in hospital preparedness program funds annually. They had to name their healthcare coalitions. So that drove the official creation of those coalitions. Again, each one a little different. So this is the coalition development in Pennsylvania. Why do we need to transition to coalitions? Well, the government kind of put a little purse string on there that says we need to. But again, this goes back to 2012. In order to be a coalition, you must have some of those core partners. You must have at least 2 hospitals. You must have an emergency management agency. You must have a public health agency. And you must have an EMS agency. If you have those 4 core, you can have a coalition. Then there's 17 other provider types under CMS that can come into the coalition as well. That's the nursing homes, the dialysis centers, so on and so forth. To establish them is to build community resilience. So you want all those things, but you want a collaborative effort amongst everyone. There you see the little circle that I'm going to talk about ASPR. ASPR is the Assistant Secretary for Preparedness and Response from Health and Human Services at the federal level. So when I say ASPR, and you're going to see a picture of an ASPR up here, This is where the guidance comes down from. These are all the, again, those 4 cores, and then your surroundings, and all these other lists that should be part of a coalition. I don't think we hit on all of them. We're starting to get some schools that want to be involved now because we have some things to offer, especially in Pennsylvania for the coalitions. We do have governments that are involved. Why? I took part of my thing, right patient, right place, right treatment. We want to make sure they're at the right place, the right time, and have the right resources during an emergency. Decrease deaths, injuries, and make sure we give them the care that they expect. That's what coalitions are all about. The other thing that coalitions do is they truly make our staff happy. Some of you might not remember, but the Pope came to Philadelphia a few years ago. We had 6 hospitals in what was called the secure zone. Secure zone meant you couldn't drive in it. So for 5 days, those hospitals could not get deliveries. They could not get trash out. They slept staff in. So a hospital that normally slept 200 people during a snowstorm had 750 people sleeping over so they could make sure that they had shift changes. What happened to their employee satisfaction surveys during the papal visit? You think they went down? They had to sleep there for 5 days. Would you be upset about that? You would. Their employee satisfaction surveys went through the roof. It was the highest they had had in years because they planned and prepared for it and knew it would be a downturn. So they planned movie nights. They had popcorn. They did it on rotating shifts so that night shift had the exact same stuff during the day. They fed them well, didn't make them pay for the food, and they were prepared. Were they busy? No. We had a lot of empty beds in Philadelphia, especially in those 6 hospitals. But everybody was a part of it. In the preparedness effort, everybody was involved, and it worked out fantastic. It's the same thing when we're dealing with natural disasters. If you know it's hurricane season and you're working at a facility, even here in the eastern part of Pennsylvania, and you could be hit, then we need to think about that stuff and talk about it ahead of time. That's what coalitions help do as well. This, speaking of which, is Hurricane Sandy. This was one of the drivers as well when coalition started. Actually, our team formed in 2012, and this happened 3 months after the formation of our team. 7,300 patients transferred from hospitals, nursing homes, and adult care facilities. 7,300 patients moved. 1,800 patients had a secondary movement after that. There were 158 impacted healthcare facilities in the state of Pennsylvania. 158. Were we on CNN? No. You know why? Because only one healthcare facility in the state of Pennsylvania evacuated, and it was a 30-person nursing home in Bucks County, and the reason they left, they had a bus sitting outside, and their sister facility was a quarter mile down the street, and they left before we could get to them. But our preparedness plans were so good, we were able to shelter the rest of those patients in Pennsylvania in their facilities and maintain them in a safe, effective environment until we got power back on. So a couple of the pictures. That one is actually out in New York. That's bringing patients down a dark stair tower that had no power in the facility by flashlights, cell phones, and whatever else they could have. They also took fuel in 5-gallon jerry cans up the steps to fuel the generator. It wasn't in their plans. Okay. Some of the assets that we have here in Pennsylvania. Coalition engagement, where it comes from. Okay. Planning and response integration is probably the key on that. We want everybody to be working together. Why do we need leaders and new leaders coming in the field engaged in this? A, it's the right thing to do. B, we're going to get into in the events. If you can reopen your facility because you had preparedness plans, you had arrangements, you had agreements before your competitor can, or you can remain open during the storm and your competitor can't, your population now looks at you as that guiding light. Advantages, regulatory requirement attainment. Yeah, we'll check the box. You join a coalition, we'll make sure we check that box, that you hit those regulatory requirements. Single point of contact for multiple resources. You can call Jason tonight. I'll give you all his business card and cell phone number. Call him tonight at 2:30. Find out whether he's got a generator or portable monitors or oxygen or whatever you want to ask him for, and see if he can get it. I'm kidding. Don't call him at 2:30. But yes, he would answer. Okay, as Jim will attest to, that's what the coalition is. It's that 24-hour resource to be able to get to those things. Information sharing. We talked about communication. Information sharing is always the fatal flaw in every incident. We address this a little bit in Pennsylvania. Doesn't mean we're great at it. We have an information sharing platform that we use all across the state for all of our partners, from the hospitals to the nursing homes to public health to the coroners. Thank you, Jason, for taking care of that this weekend. They're from birth to the grave. All those healthcare partners are involved now on this information sharing platform. So when something bad does happen, Amtrak 188, when the train went off the tracks, we were able to communicate to every single hospital on one system, give them updates that they needed, and track all the patients from the wreck. Pennsylvania is way ahead of a lot of states because of that. So our system's called Knowledge Center. You'll see something here in a moment. What we want from the leaders in healthcare, we want you to support the staff in regional and local preparedness efforts. One of the problems while I was at the facility, emergency preparedness is a non-revenue generating department. It's a bad thing in preparedness, in healthcare today. If you can't produce revenue, it's a problem. I'm working with our legal counsel at HAP now on a couple of talks. What happens if I don't do preparedness and I am Memorial and I lose those patients? You weren't prepared. I happen to know my attorney over here. The liability factors behind not being prepared today drive preparedness, but we need leadership buy-in to keep that going. Jason's going to cover these because this is his area and this is the Southwest Coalition. So he's going to give you an overview of what one of our coalitions looks like here in Southwest.
So what you see behind you is our mission and vision here in southwestern Pennsylvania. As we started this process, Mark kind of gave you an idea of what the federal government expects from a coalition. Let's take a step back to prior to 2017, that hospital preparedness program funding was going directly to the facilities. As a healthcare emergency manager in 2007, I had a grant coming into my facility. I had a 350-bed facility. I was getting about $180,000 a year. It was a great time to be a hospital emergency management coordinator. I had a budget coming directly from the feds. 2017, they said, well, we're not going to issue that funding to the facility anymore. We're going to combine that together. You're going to force these, we're going to create these coalitions. So we're going to take all of that funding from those individual facilities, put it into a big bucket, and we need to open it up to all of healthcare. So when we started down this path, and these two gentlemen sitting in the front row were instrumental in bringing that together, of how do we bring all of those other organizations into the facility? How do we take what was funding for 43 acute care facilities in southwestern Pennsylvania and bring that to everyone else? So this was the original stages of the development of the coalition and how that really worked. We have a board of directors. Down here on the bottom, you see all of our different committees. Some of your classmates are even part of some of these committees. And the committees drive the different aspects of healthcare, and we have this community providers group at the top. That community providers group is really a catch-all. If we don't have a committee for our ambulatory surgical centers, all of those folks, they're there in that group planning together until we can identify, yes, there's a need for you to break off into your own committee, and our current bylaws allow that to occur. Set up underneath the capabilities that ASPR gives us, we also identify these work groups that focus specifically on the rules or some of the recommendations that the federal government is looking for. Then we have all these ancillary people up here at the top that kind of work for the board. Myself, a public health preparedness coordinator from the Department of Health, our EMS councils across the state. And we also have this representation to Region 13 Task Force, which is our EMA directors across the state. So we all come together. Now that this has grown, I'm trying to count the number of meetings that I attend a different month, or a month, where essentially each one of those boxes below the blue here is another meeting or a preparedness meeting by those individual providers. The capabilities are a mixture, or the work groups are a mixture of all of those committees, and then ultimately directed by a board. Just to give you an idea from a funding standpoint, Southwestern Pennsylvania gets $846,000, $746.38 on an annual basis. Why do I know that? These guys make me responsible for it to say where that currently sits. How we're structured, again, the committee, each committee is identified, has a chair and co-chair, and they build a representative to each one of those capabilities. We meet on a monthly, sometimes a bi-weekly basis, depending on which committee it is and what's currently going on. Identify and prioritize some of the planning that we're currently doing, setting up training. This past month, I think I've talked about infectious disease. This was infectious disease month. So coalitions in partnership with the Ebola treatment facilities across the state, as well as the coalitions, came together for frontline facility readiness for highly infectious disease training. That was one of the big pushes this particular month. We've implemented those work groups and developed the teams to address building our plan. How do we respond in the region if one of those bad days were to occur? If a Las Vegas style event, 200 people, how do we take 200 and some people into the healthcare system at a moment's notice? Sometimes it's a difficult answer to provide, but we need to plan for how we would do that if it came to be. Again, our system across the state, Mark's going to talk to you more about that.
Slide got in the wrong spot. Sorry, Jason. I think it's still you. Okay, and Jason's going to stay up because we're going to talk about some events now. But this is the map of Pennsylvania. These are the 9 healthcare coalitions. You'll see we're in that left-hand side blue box. Jason has the largest geographical healthcare coalition in the state and the second most for healthcare population across the state. The little blue one down there in Philly has the largest healthcare population. And the shortest geography. And you'll see overlaid our HAP staff. There are 5 regional managers and a deputy director positioned across those coalitions to support them operationally. Just yesterday, the guys were doing an exercise up in the central part of the state, and we had a hospital that went black. And right now, Jim's hair on his arms just stood up. When I say went black, they lost commercial power and their generators didn't kick on. 8 patients or 10 on vents. 8 patients on ventilators. I want you to think about being a nurse and you're responsible for those 8 patients on vents, and now power goes out and your generator doesn't kick on. Do you know what you need to be doing at that point? It's not a fun process. So for 10 minutes, they were taking care of those patients manually. Our team happened to be close, went over and supported those operations. Systems came back up. But they're strategically located throughout the state to support our healthcare coalitions. Now we're going to get into the lessons learned part. We're going to talk about some past events, and we're going to talk about events that fortunately or unfortunately, fortunately for you, because you get to hear some of the stories, unfortunately for the people that we had to be there, that Jason and I were able to be at outside of this state as well as inside. So this is Hurricane Katrina. This is what started a lot of the preparedness regulations, okay? This is St. Bernard's Parish. This is St. Rita's Nursing Home. Some of you may have a problem seeing it. Can anybody tell me what that line on the wall is? That's the watermark. Over 24 residents of that nursing home perished.
Memorial Medical Center, Mark mentioned before, it's all about the book 5 Days of Memorial. They finally tore that hospital down last year. Hurricane Katrina was 2006.
This is why preparedness regulations exist. Okay? These are some of the ones across Pennsylvania. This is a slide that we use for our team when we're talking about different things. Hurricane Sandy is across the top. We were cited by the Office of the Inspector General for best-in-class response and return on investment because of federal monies we have put into our programs regarding the Hurricane Superstorm Sandy response. That is in suburban Philadelphia. This is our State Medical Assistance Team 3, which is outside of the Philadelphia area. You all are too young to remember this. The people up front will remember MASH. Look it up, it's an old-time TV show. It was an Army hospital with tents. That State Medical Assistance Team is what I like to refer to as MASH on steroids. They have a bunch of blow-up tents, and they can put a 100-bed ICU-level hospital in the parking lot of this facility in about an hour. Okay, so they're really good. That's during a response to a trauma center in northeastern Pennsylvania that was having severe power issues, and we couldn't move the patients out. They were there to support. This is a generator from FEMA coming to support that facility, and these are Army Corps of Engineer guys reading generators to make sure that we're making the connections appropriately. Portable heater in the stairwell of a hospital that didn't have its heat connected to the generator, and it was cold during Hurricane Sandy after it came through, so we had to support them with some heat. Over here on the left, that's Amtrak 188. It derailed in Philadelphia late one night. 218 patients, an immediate surge into the acute care facilities in Philadelphia. I will tell you that is the first documented Uber transport to a hospital that I know of in the country, because we documented it. And I will tell you that Uber driver made a little extra. He passed 5 other hospitals getting to the one that he dropped them off at. I guess he Googled the closest hospital when they showed up, and, well, he didn't pick the right one. But that was also our first real-world test in Pennsylvania of patient tracking. We were able to track those 218 patients once they got to the facility, and we tracked one patient for a little over 6 months. We know the 3 different rooms he was at Temple University Hospital, from ICU on down. We know the private ambulance company that took him to the rehab, and we know the rooms he was in until he was discharged. Hasn't been done before in this country, and we were able to do it in Pennsylvania using our knowledge center system. That also is Amtrak. This was one of Jason's. this is I-78 near Harrisburg, and it was Valentine's Day.
It's the Valentine weekend, massive cars. 68 vehicles, 72 people transported to 12 hospitals in 9 different counties that cross 3 coalitions. It was an awesome day trying to keep track of who's who in the zoo, in the middle of a blizzard. That's the middle of I-78, out in the middle of Berks County is where the event actually took place at. So to access the scene or to get away from the scene, you couldn't use the interstate. Depending on what side of the incident they were on, really focused on where they could actually transport that patient to without having to divert and take a lot of back roads to make that occur. Significant piece of that event, from the aftermath of it, being able to provide a report to law enforcement of here's all of the people that were involved in that event. We quickly sent an action request out to all of these facilities to say start tracking the patients that are coming to your facilities from these events. We were able to provide a report back to the state police who were investigating the crash afterwards to say here's where those 68 or 72 people ultimately ended up. We didn't share information or the names of the individuals, essentially just a sex, age, and what their chief complaint was at the time. Through their investigative techniques, they were able to at least narrow that down. But from the state trooper that was responsible for investigating that event afterwards, we saved him a significant amount of time. I'll back up just to Amtrak 188. We talk about the situational awareness platform, and we're looking at the lessons learned. What did we learn from that particular event? My biggest takeaway from it, Temple University Hospital was at 108% capacity that night, before the train went off the track. An hour and a half into the event, into the rescue, there was a gang shooting a block away from their facility. They took 5 patients with GSWs into the facility. Took a total 56 patients into their facility that night at 108% capacity. Early notification, 2 minutes after the train went off the track, the hospital got their first notification that this was occurring. It was a couple of minutes later that we were able to confirm that it was a passenger train and not another coal car that historically has gone off the tracks in that particular curve. So that advanced notification was huge. In both of these events, that advanced notification was huge. In the I-78, there's a huge difference between Pottsville and Pottstown, if you are familiar with Pennsylvania geography. We had some EMS folks that got those confused. The good thing about our patient tracking system is we didn't lose those patients. Even though the provider left and went to Pottstown instead of Pottsville where they were supposed to be going, we were still able to account for that patient in the aftermath and get them reunited with their family and back to the right side of the state where they intended to be.
And Jason brings up that notification. During Amtrak, the city's MCI alert to the hospitals went out 30 minutes after the coalition's alert to the facilities. 30 minutes difference in a hospital setting for an MCI, day and night. Okay, so that's where a coalition paid off. That's that MASH on steroids. That's them during the papal visit set up. They were medical station 1 next to the stage where the Pope was. Ebola, we'll get into that, but I'll ask you a question. Does Pennsylvania need to worry about Ebola? 70% of the returning travelers from West Africa come to Pennsylvania. Little stat that a lot of people don't know. Of that 70, 90% go to a swath between Delaware County and Philadelphia. We just had a PUI 2 months ago in Philadelphia that got off a plane from the Democratic Republic of the Congo less than 24 hours beforehand, found unresponsive in a hotel room he was wet, we'll put it that way. From the top and the bottom, unresponsive. Worked in the Ebola camps in DRC. That's what can happen in Pennsylvania. That one down there, unfortunately, is an active shooter that took place in Mercy Fitzgerald Hospital outside of Philadelphia. So shootings occur, unfortunately, in our facilities as well. I'm going to talk about Hurricane Harvey. If you don't know, Hurricane Harvey is the one that hit Houston 2 years ago. Hurricane Harvey was not a typical hurricane. Most hurricanes come blowing through. They got a lot of rain, they got a lot of wind, they do tornadoes, and they're gone in 24 hours. Hurricane Harvey hung around for about 3 days and dropped historic amounts of water on the Houston metro area. Over 60 inches of rain in a facility. I keep this picture in here because I told you about the Asper. The gentleman seated right there is Admiral Craig Vanderwagen. He was the first Asper in the country. I keep that there because, to me, I worked with God for a week, okay? This is one of the people in healthcare that preparedness, that we know and love. We got lucky, and Jason, myself, and our other counterpart, Scott, we were a 4-man team in the Houston area. We ran the largest healthcare provider in the Houston area's market for a bunch of days while we were down there. Assisted them in running their market. This is what Houston looked like 3 days after Harvey. 3 days after, there was still this much water. How would you like that to be your morning commute? And it'll get better. You could get on the highway at certain points, but you couldn't get off. So people were stranded up on it. That's what the healthcare workers' own homes look like. The agency that we were working for, 60% of their staff? 60% of their staff were impacted by the hurricane. They either had flooding in their own homes or their homes were gone. What do your staffing ratios look like at that point? Tough. This is where the preparedness efforts come in. What are the plans? Are your family still in those houses while you're sitting in the hospital working? Or where are they? We stress preparedness plans for the individuals so that we can keep the facilities open as well. If you've never seen this picture, and it might be hard to see in the back, this is 5 ladies in a nursing home, La Vida Bella, which is in Dickinson, Texas. What you might not see is that lady's crocheting. What might be hard in the back to see is this is water. This lady is in chest-deep water in this nursing home. All 5 of them in chest-deep water. The facility had done all their preparedness plans. Sometimes preparedness is kind of like security. It's an umbrella. So you hold the umbrella over you and you stay dry. But sometimes the rain comes sideways. Sometimes you need those contingency plans. This facility had put a 50-year flood map over top of their facility. They should have gotten about an inch of water into about an eighth of their facility at a 50-year flood. So they did the right things. They had staff staying in because they were worried about flooded roads. They put sandbags around their doors, 1.5 feet tall. A couple inches of water can't go over 1.5 feet worth of sandbags, right? Problem is the levee not far away from them, which had been certified, was fine. It was checked 12 hours before this picture was taken, and it was fine. An hour after it was checked, it catastrophically failed and dumped millions of gallons of water into the neighborhood and put 3.5, 4 feet of water into the facility. And at that point, you can't do rescues because the water's running too fast. They couldn't come in by air because of the weather. There were a lot of things playing against it. But this one's got a happy ending. Those are the same ladies that were in the picture. That is at their temporary facility. And they're doing fine. Their facility reopened. They now have different preparedness plans. This is another one down there. This is Cypress Glen. I keep this picture in because do those look like fireboats or do those look like a fishing boat? This is one of the greatest volunteer organizations in the country. This is called the Cajun Navy. The Cajun Navy are a bunch of volunteers with boats that started after Katrina, and they go to every disaster that has a hurricane all over the country. and they are organized. They are more organized than some of the Texas emergency responders were. We actually use them to help move stuff. But they had to verify who you were. You had to have a certain call sign. They use an app called Zello, by the way. They knew how much weight each one of those boats could hold, how much fuel it had left, and what type of boats they could offer to you. They're incredible. So this is Cypress Glen. Cypress Glen started to flood. They knew they needed, again, this is one that wasn't supposed to get this high, but when you have 60+ inches of rain and less than 24 hours beforehand, the National Weather Service is telling you you're only getting 18 inches of rain, and then next thing you're at 60 and the roads are already cut coming into the facility, some things change. So they went out to the local emergency managers. The local emergency managers used the Cajun Navy and some of the local responders, and they came in and they got everybody out of the facility safely. Everyone. Not one negative impact to care from the associated one.
So from a lessons learned standpoint, Mark said 60% of their staff. This is a 28 hospital system in the greater Houston area. 60% of their staff are affected. I think the actual number is 60% either lost their home or their main mode of transportation in the storm. What are some of your concerns as a healthcare provider or a healthcare administrator at that point, knowing that 60% of your staff is affected? Behavioral health concerns? Can my staff continue to function? Looking at back at this particular event, this is Houston. This is where a lot of people evacuated to when they left Louisiana after Katrina. 27% of that 60% of their total staff lived through Katrina, evacuated out of Louisiana, repatriated to Houston, and now is affected again 10 years later.
Hurricane Irma was a little different than Harvey. Irma was a blowhard. Irma didn't have a lot of rain. Irma had really bad winds, a lot of tornadoes. Irma came through really quick, but really nasty. If you haven't read this one, read it. It's still in the criminal courts. This is Hollywood Hills Nursing Home. Hollywood Hills, at this point, did not know what a healthcare coalition was. They were not part of it. Hollywood Hills was located across the street from a 250-bed hospital, not one that we were involved with. Ours was 10 miles away, I think. What happened is Hollywood Hills lost power when Irma came through. If you've ever been to West Florida, it gets a little hot. Irma came through, the next morning it was 94 degrees with humidity in the 90%. The air conditioning at Hollywood Hills was not connected to any generator. What happened to the temperatures in the building? They went catastrophic very rapidly. Here's where we will differ from some of the things you see in the news media. The news media says that the nursing home administrator is completely to blame for the deaths of the 12 people in this nursing home. I'll tell you differently. The nursing home administrator made multiple calls to the local police, the fire department, the county government, and even called the governor's office 3 times to ask for help. That they had temperatures rising and people that couldn't stand the heat, and people were getting bad. So when the first one started to have severe respiratory distress over the heat, they called 911 for an ambulance. Ambulance crew came in, said, boy, it's hot in here. Took the lady, went to the hospital. 15 minutes later, they made the second 911 call. Ambulance crew came in, said, wow, it's really hot in here. Took the patient and went. The next 911 call was about 20 minutes after that. That ambulance crew said, there's a problem here. In between call number 1 and call number 2, the administrator who had never met the hospital CEO across the street called the hospital, because they're not part of the coalition, this nursing home wasn't, and said, we have no air conditioning and I got people that are not doing well, can we come over? Hospital administrator said, I'd love to, but it was a 250-bed hospital that was housing over 1,000 people. Not only were they full with 250 patients, they were sleeping staff in, and they had community that just walked in during the storm that had nothing else to do. And they had animals. There was no room at the inn. They called the county and asked for shelter locations. That county had closed all their shelters because nobody was using them. And they didn't relay them to the other county not far away that was there. The unfortunate part of this is when they called the governor's office and the number, they were told that somebody would get back to them, and nobody did. Governor Rick Scott is a former healthcare executive. It's a shame. 12 people lost their lives because of it. That's them in the parking lot when they got there. This is what a response kind of looks like. This was the think tank during Irma for the facilities that we were responsible for. Where you see red, that's a problem. But we use color-coded stickies along with their electronic stuff to kind of keep a visual board. So this is all their facilities with different statuses that we needed to track. Again, you'll see them stuck on the windowsill. We're watching whiteboards, pictures of the facility. One of the things to remember during a hurricane, can you sustain 110 mile per hour winds? Can you sustain objects being thrown at your building in 110 mile per hour winds? So on the preparedness aspect, we were looking at what facilities could withstand what, who was the most at risk, and then de-risking those facilities. So moving patients ahead of time. Do we need, and if I jump back to Houston, 68 NICU babies were moved pre-Harvey. And there were other healthcare organizations that said, you're crazy, why are you moving them all? It's just going to be rain. That hospital was, East Houston was leveled a month or so ago.
Yeah.
Okay. That hospital was taken down to the ground because the administrative team that was left in the hospital, those 10 individuals, was rescued by boat out of the second floor windows. There was nothing left. But meanwhile, when they were moving those 68 NICU babies, we were told, are you crazy? Why are you moving all these babies and patients? There's no reason. Because we looked at the risk, we took it beyond, and made sure the patients were safe. That organization made the right call ahead of time to protect the individuals. So just a couple more. Now, Holly, how am I doing? Wrap it up. All right, we'll wrap it this one. This is the Barclay Friends Nursing Home. Some people can't talk about this. I can. I'm not part of the suit. This is a nursing home, and this has a lot of real good lessons learned and best practices. Nursing home was established in 1893. It's in Westchester, Pennsylvania, right near the university. It is a bedroom community, very old. As you can see, the home was established way back when. This is what the facility looked like. So this is assisted living and memory care, Alzheimer unit, and this was the skilled. 137 residents, 15 staff. No fire, the fire alarm did not sound. The first notification the county got was a 911 call from the facility saying there's smoke in the building and we heard an explosion. 15 staff, 137 residents, 10:30 at night, 30 degrees, wind chills in the 20s. Some of those, 27 of those were in the dementia unit. This is 30 minutes into the fire. This is the community helping pull some of the residents from the facility after the staff did it. That's what it looked like the morning after. let me see what else I have here. Okay. This facility joined the coalition 90 days before this event. 30 days before the event, we did an evacuation exercise with them. Well, I didn't tell you, and Jason's one too. Jason and I are both former fire chiefs. When I pulled up on this scene, I knew what their census was. I knew what the fire looked like. I knew how quick I got there. There was going to be a lot of people that didn't make it. And it was okay. As a fire chief, you went, that's okay. One of the big things is news media in events like this. You have to be prepared to handle that. When the patients were being evacuated from this facility, they were brought out into the street. Guess who was at the corner with a camera? The news media. Guess who had a helicopter circling above, because it was 10:45 at night, and I think the west coast of Pennsylvania is the same as the east coast. News is at 11 p.m. Guess what their lead story was? This nursing home fire. So now you've got all the reporters and everything else showing the pictures of these residents. So come Friday morning, we're trying to account for residents and staff. Regional response, the coalition did an amazing thing. And I think we get to it here. No, we don't, so I'll do it. We were down to, at one point, one of the problems with this nursing home was when we asked them for their census of who they had in the building, the closest sheet they gave us was 72 hours old. 72 hours old in a nursing home, for those of you that aren't there yet, might as well be a week. So many discharges, so many new arrivals, some that were at the hospital. We asked them for their staff counts because unfortunately a couple of the staff members brought people out of the building and then they left. So we asked them for their staff rosters. We need contacts so that we can verify that all these people are safe. Lesson learned. We need updated censuses so that we can account for people. When we tried to call one staff member, the phone had been turned off 6 months prior. So even though she provided that number when she was supposed to, it wasn't kept up to date except for maybe on a yearly or unless the employee came and changed it. When we sent a police officer at 4 o'clock in the morning to go knock on the door of the address she had moved months prior. We woke somebody else up who told us that. Those updates are really necessary to account for people in an emergency. So at one point during this, I will tell you that we got it down to 23 that we couldn't account for. About 3 hours into the fire, we had 23 people. And I looked at our other counterpart, and we were in the command trailer, and I said, you know what, that isn't so bad. 157 in, something happened, the roof collapsed. The roof collapsed 11 minutes into the fire. The roof of the structure collapsed. They did a great job, but you know what? This happens. The end result, 4 people. 4 people perished in the fire, a husband and wife and 2 ladies. The staff did an amazing job with evacuation. Amazing. What they did, they said when the fire department pulled up that there were people just laying on the grass right outside the doors. They were going in and out, and they followed what we had taught them, the evacuation teams. And they said, well, we didn't get to use all those nifty carries. We didn't get to use some of the baskets and stuff. They simply grabbed them and dragged them. And a paramedic tells a story about going up to a lady, and she's got blood under her legs. And she said, what happened to you? And the lady said, I don't know. I think I got dragged out of the building. She was one of the most severely injured, and it's because she opened up some sores that were on her leg that were pre-existing. Everybody else was doing great. The ambulance squad that was a quarter mile away, we moved all the patients there and re-triaged them. Because you got to remember with the patients and residents that are in our facilities, they're more susceptible to things like this. So when you get them around smoke, you put them out in 20-degree weather with wind chills, they can downgrade. So you have to continually reassess the patients as you're going through these events. And that's what we did. Pennsylvania, do you have tornadoes? Yes, you do. Ask Rolling Fields Nursing Home.
We'll end on a good note. Mark's told you all these stories about how everybody, somebody was injured. This is Rolling Fields Elder Care, Conneautville, Pennsylvania, October 2nd, 2018. Hit by an EF2 tornado. They were given about 7 minutes of warning when everyone's phone went off that a tornado was coming. Yes, we got earlier weather reports in the morning that we were going to have a fairly strong thunderstorm. They got the notice that a tornado was possible to touch down. They were able to get everybody out of the patient rooms and into the hallway and secure them. This is a shot of one of their patient rooms after the roof was ripped off of this building. Do you have the statistics in here? I'm trying to remember them off the top of my head. It was over 120 patients that were in the facility at the time of the event. If you back up to the other slide. This is one of their, what they call their patio homes. It was an elder community. This was the first person that was actually transported to the hospital. This young lady actually got the notification on her TV. She got up from where she was in her living room, went into her bedroom, and she was actually in that closet. Where her clothes are still neatly hung, she was in that closet. Came out to that, and she had a nice gash on her leg from flying debris. She was ultimately the first person to leave that particular event. Big thing for this particular facility, the community support. I was in Monroeville at the time of this event, drove to Conneautville. For those of you familiar with the area, that's a pretty good distance. I'm not going to tell you how quickly I was able to accomplish that feat. But when I pulled into the Conneautville High School, they had already moved most of the hospital beds, the oxygen concentrators. It looked like a long-term care facility set up in that particular room. Trying to find beds in northwestern Pennsylvania for 120 residents now. How easy do you think that is to accomplish? This particular facility did a fantastic job of getting everyone safe, keeping them safe. They actually evacuated this facility not once but twice that evening. Right after the storm, they all evacuated to the outside, or they brought everybody into the hallway. Through the storm, they recognized that there was a gas leak in their facility. They all moved outside. Then they got the notification that the other tornado was coming. So they made the decision that inside the building with the gas leak was safer than being outside with the tornado. Ultimately, all of these patients were placed. I was back home. I live in the Mars area. I pulled back into my driveway about 4:30 in the morning. This event occurred at 3 o'clock in the afternoon. All of those patients were placed in a like facility that could continue their care. Most of them remained there for, I think 17 days was the number, until they could be brought back into this facility. So this was the worst part of their wing. They were able to secure the other portion of the wing and start bringing people home 17 days later. For them, that was probably a huge benefit of being able to get their patients back to them in 17 days. I think any longer, some of those patients would have said, yeah, I found a new home at this point, and they would have been changing the name on the building or doing something else for their business continuity.
Here's the one thing we want to stress. You're not just going to be a nurse. You're not just going to be anything in healthcare. If you're not prepared for this to occur in this day and age, our weather is changed. We have new normals now. Sandy, Harvey, Irma, Florence, Michael. The names keep coming. Snowstorms get even worse. It used to be less than 24 hours we were back out. Now it can be even more. Our infrastructure's older. You need to be part of preparedness. What happens if Vegas happens here? We have to be able to surge. Be part of preparedness. Make sure that you have a plan, even you independently. this was real big after 9/11. Who you gonna call? Make sure you have a plan for your family, because without a plan for you and your family, then you're no good to your facility, and then we're no good to our people. And what happens if we're no good to our people and we can't care for them? They go somewhere else. That's where preparedness does make money. If you're prepared, we make money. Thank you all for your time.
So Maria, we're going to start with you. If you can tell us where you are, what your position is, and your question I want to ask, taking off what Mark has said about communication and coalitions, how do you, at UPMC, how do you keep the connection to the community, and what technology are you using?
My name is Maria Gayette. I am an emergency physician. I'm the Chief of Emergency Services at UPMC Shadyside. I am also the immediate past president of the Pennsylvania College of Emergency Physicians, which is a physician organization of 1,800 emergency physicians across the state of Pennsylvania. UPMC has gotten the opportunity to test out our system a couple times over the past few years, and we have multiple levels because this involves multiple different types of disasters. So there's a natural disaster where we may have something that doesn't come on in minutes, but comes on in hours over a day, but lasts a little bit longer, like Snowmageddon in 2010, where folks couldn't get to and from the hospital, patients couldn't get to and from the hospital. We've had unfortunately, the Tree of Life shooting to test out what happens in a short-term mass casualty incident, to allow us to see, hey, how quickly can we respond in that context, and then Ebola or even flu, where we have a rapid development of an infectious disease that really causes a surge in our capacity and in our needs. So UPMC uses a notification system for the employees where, as long as we have your phone number, as long as we have that contact information, you get both a text message and a voicemail when there is an occurrence of something, to get everybody on the same page to recognize, hey, this is happening. There have been a couple of incidents where there were potential active shooters, or thought that there was an active shooter in or near the hospitals, and those incidents go out to everybody who works there so that we know what's going on, so that we know, hey, this is not where we're headed right now. That also, our communication plan includes notifying our emergency command center in the city of Pittsburgh, because we need EMS to know where they can or cannot bring patients to. And then within our organization on a smaller level, for the smaller groups that are involved in disasters, we have communication tools like GroupMe, which is not fancy technology, but a newer technology, or even a group text message string. So for the day of the Tree of Life shooting, our EMS physicians, one of whom lives right around the corner from there, were on a group text message going minute to minute in terms of what is the information about this, what do we need to be prepared for, where can we go to help, what kind of help do you need. Our trauma surgeons similarly were on a GroupMe text where they could say, hey, we have an unknown number of people coming in, we need more help at the hospitals. So I think the communications tools go from the larger level of being able to put out the information and say, hey, this is going on and we need help, to the smaller level of which groups need help. But having that in place beforehand, because you really can't put that into place at the time of. And then the next level of communications, which I think is just as important, is to have the hospital system ready to get that information out there to the community. So flu is ramping up in March. What information do we need to get out there? We had a potential measles outbreak 3 or 4 years ago, and there was a potential exposure within our hospital system. And how do we get that information out there to patients so that they're not coming to the area where they could potentially be exposed, and so that we're not taking people who have been exposed and putting them back into that area. So that communication out to the community is just as important as the communication out to our employees.
Cell phones have definitely helped communication.
Yes.
You know, in the past, 25 years ago, you have telephone, phone trays that you have to, one calls, the next person calls the next. We have certainly gotten a better communication system. Dave Kish from St. Clair. Question for you is regarding regional support and being at St. Clair Hospital, what type of regional activities do you participate in to be prepared? As Mark has said, the whole purpose of the plan is to be prepared. How are you preparing yourself regionally?
That's a great question. We're part of the Healthcare Coalition of Southwestern Pennsylvania. I actually am the chairperson for our Capability 3 team as one of the board members for that Healthcare Coalition. So very active at our hospital in participation with the coalition in preparedness and planning. About a year ago, a little over a year ago, I reached out to Jason and said, hey Jason, we've got an idea. We want to be the lead on the regional disaster drill. And he said, what are you thinking about? I said, well, St. Clair is going to be planning this very large outpatient center. We're going to be digging this very big hole right near the hospital. I said, we want to do a drill where we're going to evacuate the whole facility. We're going to simulate evacuating the whole facility because the drill is going to be based on the concept that as they dug this hole for the new outpatient center, that they strike an undocumented mine shaft in western Pennsylvania. Now we start to have building collapse. So what do we have to do to evacuate all those patients? So we included our regional EMS providers, our public safety officials from around the area, the Healthcare Coalition, a lot of folks from nursing homes and skilled facilities around, and we brought them all into the table at St. Clair and actually drilled that. And like I said, so we figured we would take an actual thing that was going on at the hospital, was contemporary for our organization, and then said, how can we make this into a preparedness activity if something would happen? On the bigger scale, that was a huge thing, but realistically speaking, as many healthcare administrators know, whenever you're doing construction around the hospital, somebody just happens to dig into something that they didn't think was there. Maybe it was that big power feed to the hospital that they thought was just maybe a little bit deeper, and you lose your power and your generators. So we said, let's make this proactive and kind of learn from it. And I think we had a lot of lessons learned. We're still learning from it, and it's helped guide some of us in some of our discussions at the board level from the Healthcare Coalition as to what we need to be thinking about. We're talking with our local skilled facilities right now about generators and how do you get them hooked up to generator power, and how can the coalition take part of that?
The time to be meeting the chief of the fire chief or the police is not during a disaster. It's,
yep.
And I know, having worked at St. Clair, inviting those individuals in to take a look at the hospital, know that they know what's the hospital's about, where things are located, and making sure that communication.
That's exactly right, and putting the face to the name. And our healthcare, our hazard vulnerability analysis, our risk analysis that we use, we actually share with our local emergency manager in Mount Lebanon. We also share with Jason in the region, say, take a look at this. Does this fit? Does it make sense? Pressure test it for us so that we make sure we're not missing anything.
Kind of taking off, Dave, as far as your hazard vulnerability analysis, and Mark alluded to it during the presentation that every hospital has a different hazard vulnerability analysis based on where they're located. What's top on St. Clair's list of hazard vulnerability?
Weather, weather, and weather. That's usually our biggest one, and it just it speaks exactly what Mark was talking about. Whether it's a tornado or storms, we had a microburst several years at the hospital that took out our main feed, our electrical feed to the hospital, because that same day we happened to have an employee recognition with a big tent out back. Well, that tent got picked up and thrown down over the hill and went right across one of our main power feeds. And that generator didn't function the way it should. So that's one. Weather and snow, all those kind of ice storms, those are the most common.
And I was there when that happened, and the director of engineering was the calmest guy. He was just like, he was handling it quite well without getting too excited.
Yep.
Now, Jim Hassan from Allegheny Health Network. Allegheny is very integral into the community, and there's a lot of resources. What is Allegheny doing to keep connected with all of those nursing homes and other facilities, and what's the strategies that you're using?
Sure, yeah, so as Dave mentioned, we're also an active participant in the coalition, and that's a tremendous part of preparedness activities for our entire region. So I think, from our perspective and looking at one strategy is we can't all, or none of us can operate in a silo, right? We all have to be taking part in these proactive conversations because, as you mentioned, at the time of an emergency is not the time to meet the fire chief. Right, so it's actively engaging in those conversations and those planning efforts, and knowing what our capabilities and resources are and how to activate them and secure them, and knowing how and when to talk to each other when an event occurs. So if something happens from the Ebola patient to a weather emergency to a water line break that is that impactful to an institution, this group here is all going to talk together. We can't operate in silos. We all have to know how to work together to get through that solution. We may be transferring patients amongst each other. Again, if it's that Ebola patient, Dr. Guyette's going to be talking with Dr. Campbell at Allegheny Health Network as to what those best strategies are. So, in the words of Dwight Eisenhower, I would say, or he said, plans when you're storming the beach are worthless. It's the planning effort that's invaluable. So, as long as everybody's in that planning effort and engaged in those conversations and know how to access those resources and activate those actual tactics. That's the most important thing. We'll sort it out from there. As long as the right people are in that conversation and know how to get their stuff and how to use that stuff, and everybody is operating on the same premise, we'll figure it out from there. We always do.
Now, you're part of a health system. You have a number of hospitals that are in your health system. How do you communicate between them? When one hospital may have a disaster, how does the other hospitals help to facilitate strategies for improvement?
Sure, yeah, early activation, as Dr. Guyette suggested, it's about activating the appropriate resources and people and bringing them all into the conversation as early as possible. And my job is to integrate those efforts, right? We're a health network. We have multiple hospitals, we have multiple service lines, business units, so that there's a process in place that when an event occurs that impacts one or can evolve into a much larger institution to impact other facilities, there's a process in place that the appropriate activations are made through some of the tools that we have in place. We have a mass communications tool that will essentially send that flag up and let the rest of our folks know that an incident has occurred and may potentially impact more than one site. So early activation is the key. And that process that Mark mentioned and Jason referred to as well as the incident command structure. Right, as long as that's a universal system that we all adhere to and follow, we all know what our role is, but it's also flexible enough that multiple people can fill that role. And if we're all adhering to that same process and everybody understands that, again, we'll figure it out from there, but that's the universal approach for all of us.
And planning is the key, as Mark had started the presentation. What are some, give us an example of one of your disaster preparedness drills.
Yeah, so I'm glad you brought that up. So Dave mentioned it when we did the St. Clair drill, as well as our large regional exercise that we completed in the fall. We had, Jason, correct me if I'm wrong, over 320 agencies participating in that. And that was not just hospitals, because traditionally this is something that hospitals did. And now with the new CMS regulations, dialysis centers, home health and hospice, ambulatory surgical centers have to have the same plans, which means that they have to test those plans as well. So through the facilitation of a large regional exercise, we were able to engage those partners so that they were able to be part of that process that was somewhat foreign to them, or they might be new to, but also they could test their plans that they worked so hard to put into place. So that was a pretty monumental exercise to get that level of involvement, and we prepared for that at least 8 months. And that was really the first time that a large coalition of that size was able to pull that together and involve those multiple healthcare providers, test those plans, and then have an improvement process for moving forward. We've already began the process for planning for our next fall exercise, which will be those 320 same healthcare providers, incorporating those lessons learned from the last exercise, and then building and strengthening their plans from that.
Those dress rehearsals do help. And,
Absolutely.
You know, having been involved in those, you know, the debriefing afterwards and finding out where your opportunities, many times communication is the key, you know, who wasn't notified, who was notified, so it does help to do those dress rehearsals. Now we're kind of now getting into Chip Franklin regarding community work and being a community paramedic. And how do you get involved whenever there's a disaster, and what type of resources do you utilize in the community?
That's a great question, because I don't know that the community paramedic model, as we've defined it, has really been involved in a disaster as yet, but it has a novel approach and a novel idea, and that is that we take our work to the patient. So our goal is, in a regular situation, is we go to the patient's house. We see the patient where they're at. We take care of their social determinants there wherever they are. And the question, of course, becomes is after a disaster, the long-term, the long stretched-out process, how does the society return back to some semblance of normalcy? And what does that look like? You know, if you have a decent-sized housing insecure population, you know, if you have a natural disaster, where are they? They're going to live somewhere. Where are they going to live? Where is their encampment going to be? And how are you going to take care of their healthcare needs when that happens? The big thing where you come out of Katrina and the other monstrous hurricanes are things like, you know, where are people getting their medicines from? You know, how are we going to address that? You know, insulin needs to be refrigerated for a period of time at least. So where are we going to get it? How are we going to address those problems? And a lot of that comes with planning. You know, and that's the key is the idea of having these plans in place and kind of building on it. My role as a community paramedic would be to sort of receive the patient after the disaster and be like, okay, how do we reestablish you to the social networks? How do we get your social security check back? How do we get your food stamps back? How do we get you connected to the right resources that we had all set up before, but then now we're suddenly we've kind of turned those upside down. You know, if you're used to going to your Rite Aid once a month and getting your medications, and your Rite Aid is no longer there because it's been wiped away, what do we need to do so that you don't fall off the radar and end up coming back into the hospital for some reasons that we could have prevented?
How do you prepare for that? Have you done any drills of that matter to?
I've not been involved in any of that planning, and I would be encouraged to do that. I would, you know, really kind of say to ourselves, okay, how do we tabletop this? You know, obviously, a disaster exercise and a disaster drill has some finite beginning and end to it, so for realistic purposes. But then, you know, to tabletop things like, okay, well, how long does it take to reestablish, you know, electrical power lines, or how long does it take to get sewer lines back in place, or how long does it take to rebuild a bridge so that, you know, a community that was on one side of the river that it depends on the community on the other side of the river for their social needs and things like that, how long is it going to take for them to get there, or so that they can get transportation back and forth?
How important communication is to knowing all those pieces of the puzzle and where they come. I did some work down in Louisiana and with the University of Louisiana and some of the other hospitals, and you know, Katrina, it was definitely before Katrina, after Katrina, and those individuals down there really wrote the Bible for health, for disaster preparedness. But you know, they are coming back around, and
you know, it's funny, Holly, you mentioned pieces of the puzzle. This is all dominoes, is the way to think about it. And if we lose one of the dominoes, the rest can fail. The idea behind preparedness and coalitions in general is, okay, we'll support that domino or support the next one down the line so that we don't lose the entire table. And we talk about community paramedicine and things of that nature. They were crucial in the recovery of those neighborhoods after Harvey, after Irma. After Harvey, there were 200 FQHCs, which is federally qualified health centers, in the Houston market. 3 days after Harvey, only 20 of them reopened. The key for healthcare at that point was, how do we take care of the populace? What do we prioritize for us to reopen? How do we get people out into the community? Do we open the freestanding ERs in those neighborhoods because Texas has them, Pennsylvania hasn't gotten there yet? Sorry. That was my political commentary for the night. But what do you prioritize to take care of those patients? Because the ER can't take another 250 visits today because there's no FQHC or there's no urgent care open or the CVS isn't open and they can't go get their pills. How do we address those community needs? And that's what preparedness is all about.
I'd like to open it up to the audience as to questions that you may have regarding emergency preparedness and disasters. Yes?
I have a question. So, for instance, St. Clair, UPMC, you guys talked about emergency preparedness, and I wanted to ask, how do you all keep track of your staff? So patients are easy, you print out a census list. What about staff? Not just nursing staff, but like if you had a disaster in your building, all of the staff, how do you account for all of that?
The schedules are housed within the unit directors, so our unit directors are responsible. So it's a team, it all builds up. So our unit directors are responsible for having those schedules. And then we have an incident command center within the hospital. So when a disaster happens, and we open that up for anything that could kind of qualify as a disaster. So we lost a patient, that incident command center opens. So within that incident command center, there is a central person who is gathering those schedules from the different unit directors to bring them up. And there's a unit director for everything, right? From environmental services up through the cafeteria, up through the nursing units. So they each have a role in that, and you have to put all those pieces together to get to the final puzzle.
Is that something that you would drill, that those activities would be drilled upon?
Yeah, so when we do our tabletop drill and when we do the broader drills, that's part of it, is at that incident command center, they're checking and making sure, do we have information from 4 West? Do we have information from the emergency department? So they have a centralized list of saying, these are the departments we need to check. And then those departmental directors are responsible for getting their information back up to them.
I would add to that too, if you're exploring your emergency notification systems, it's very important that you have two-way communication with those. Very valuable tool is that when you push out a notification to your staff, that they're able to receive that and confirm reception of that message, right? So that becomes especially important. You know, unfortunately, you know, when we began our healthcare careers, the thought of planning for active shooters in a hospital was the furthest thing from our mind. And if that occurs, you think about the people that you have to notify. The inner circle are those folks that are in that immediate radius. But you also have to think about the people who might be coming into that inner circle. And how do you reach them, and how do you notify them of something? So having that feature of being able to view the receipt of that message and who received it, so that you can follow up with additional communications and evaluate in real time the percentage and the overall depth of your reach into your staff is tremendously valuable. And to Dr. Guyette's point, that's something that when you do an emergency exercise, that's a standing component, or should be a standing component. That emergency notification process is something that gets evaluated each and every time.
Prior to cell phones, when you had the overhead announcements and you'd have those dead spots in a hospital where people couldn't hear the overhead announcement, and you had to depend upon someone going to getting them physically in those areas. If an announcement goes out and nobody hears it, what good is the announcement, right?
But I would echo all of my peers' comments up here, but I'd also say that you need to build in redundancy in your plans. What happens when the cell tower goes down? And you can't do that. So you've got to have backups to the backups. And my thing is, whatever plan you do, I like to try to make things 3 deep. So if step 1 fails, you go to step 2. Step 2 fails, what's step 3? You need to outline that up ahead of time. And to speak, I think, with Dr. Guyette's point, Sometimes it boils down to, I got to go to a runner system. So plan ahead for that, because what happens if that text message doesn't work? You know, you've got to think ahead and do some redundancy planning as well, too.
Very good. Question? Angela?
Being that we have all of these future nuclear medicine individuals here, have you thought, do you have in place anything for the situation of radiation exposure? Because, you know, these young adults do have the ability to work the Geiger counters, they understand major and minor spills, and I just wondered what was in place with that, and particularly since we are so close to these areas, just thinking back the anniversary of 50 years, I think, for 3 Mile Island, those kind of things, and also for, you know, since we're so close to the airport. So my primary question, though, has to do with the radiation piece, and I think you have a very captive audience.
There is, I'll speak and then let everybody do their individuals. There's a group out there called RITN, Radiation Injury Treatment Network, and it's a nationwide group of facilities that are able to treat patients exposed to radiation. We actually in this state conducted one of their first full-scale exercises in conjunction with, it's called NDMS, National Disaster Medical System, and that's how you move patients. It was originally designed for if there was a big earthquake in California, we would move all those patients to other parts of the country to serve them. Then the DOD got involved, and it was for bringing combat injuries back to the states from foreign soil. So this RITN network just conducted an exercise with a terrorism event in Chicago, lots of people exposed, and transporting those people to RITN facilities or areas of the country that could help care for them, both inpatient and outpatient wise. And that exercise was conducted with Pennsylvania, and they theoretically moved a bunch of patients from Chicago into the Pittsburgh and Philadelphia regions to receive RITN treatment. So those are out there, and we used, you never take anybody's word for it. So I know Jim and you will agree that if you have a person from a chemical incident, you always assume that they're clean when they get you to your facility, right? No, you always assume they're dirty. Same thing with a radiation patient. You always assume that they are dirty. You need to check them with the meters before they come into your facility, because if you let an exposed patient into your ER, now we just lost a domino and lost an ER. You look at some of the facilities going back to the anthrax attacks, there's a building in Miami that is still not occupied from '01 because of its exposure. We now have hospitals that are costing $1 billion. We need to make sure they're safe and that people are checked before they enter the doors.
And I think that's a great example of why it's important to get involved early, right? So as you begin your healthcare careers and you hear all these big words and see big titles around emergency preparedness, it's important to remember that that's not a job or a title, it's a culture. And it takes a team to respond to any one of these numerous events. So specific to a radiation event or a small scale spill event, everybody has something to contribute, and you essentially are the experts on that. So being involved early and engaging in those activities at whatever facility you land at is very important, and everybody has something to offer when it comes to planning and responding to an incident. The other thing I would say is that we are planning for the next RITN exercise. If that's something that you are involved in, we can certainly make that connection, perhaps as observers, simulated patients. Holly, we can follow up afterwards and perhaps involve some of the students here.
And there was some federal grant money and state grant money for disaster or for radiation. I know when I was at West Penn, we had some grant money that was given for
that's what's facilitating this exercise.
Tents and equipment. Good question. Any other questions? Yes.
You
requirement passed for the nursing homes to have emergency generators. What's the status in Pennsylvania for nursing homes and emergency generators?
Right now, it is only the CMS requirements that hit in Pennsylvania. So the CMS requirement does not require a generator. It requires a plan for if you were to lose commercial power. Majority of our facilities do have emergency generators. One of the problems is that maybe those facilities don't have their heating and air conditioning connected to them, so if it happens during the cold or during the warmth, then we run into a problem. Some of them are older, or maybe they only have a tank that can last 16 hours. You know, we need to make sure there's fuel. There was some movement in Pennsylvania, which died out with the last legislative body, to follow a similar type path. It never came out of committee. But like I said, there are other states that are looking at some of this, and I think that Florence and Michael, as we continue to have these events, you're going to see these regulations continue to rise. As Jason and I know from the national group that we sit on, the preparedness changes to CMS now are looking more and more like they want to head back to those type of efforts requiring those type of things. But how long before the feds get there is the question.
Good question. Other questions? Diane.
Yeah, it's kind of a question / comment. But, you know, I always find it interesting that the collaboration, you know, looks good, sounds good, but then when you get into scarcity thinking, you get to normal human behaviors like hoarding and, you know, kind of taking mine, and it doesn't end up being quite as collaborative. I always think it's interesting with the emergency situations that we maybe could be more prepared for that than we are for the day-to-day behaviors that don't allow us to have quite the collaboration. And so I guess
Saying have collaboration all the time.
Are you going to teach the day-to-day folks after you figured it out for the disasters? And we kind of said that with Ebola, because like if you're using proper infectious disease prevention techniques, you can use it for Ebola. Of course, that is a little bit more, but we don't use it for hand washing. The day-to-day things we can't get done well, right?
You bring up a great point, and I think we are getting there. Number one, Jason mentioned the frontline facility training that was done in this coalition for Ebola, highly infectious diseases, that we rolled out statewide. First state to do it, by the way, and it's a fantastic program. But that sharing thing, all right, I'll pick on UPMC. UPMC doesn't like UPenn, okay? Quakers, Pitt, I mean, it kind of changes things. But Ebola, when we go to Ebola, Hospital University of Pennsylvania is one of the 8 Ebola assessment and treatment facilities in this state. UPMC also has a facility. UPenn back then, when supplies were very limited during the 2014 outbreak, the federal government commandeered a lot of the PPE that we use for our workers, wouldn't let you order it, things like that. University of Penn wore a very certain hood. I told you they were at the epicenter. They saw 6, it's called persons under investigation, PUIs. They only had enough to functionally operate for about 8 hours with the amount of hoods that they had. So we had to use mutual aid. Guess where one of the facilities was that we used mutual aid from? It was a UPMC facility in central Pennsylvania. Jason would pick it up, and he would have to bring it to Philly if it was confirmed. We have that sharing. Measles was mentioned. Jim, that might be was that the bus with the tourists? Yes. We had a bus of tourists go through the central part of state, and measles was on the bus. We didn't find out until they were out of state. The whole involvement was that the state didn't have enough measles, immunoglobulin, Is that correct, Doc? Thanks. Vaccine to give to people, and the bad part is the one stop the bus made was also at an Amish market. Amish people are not inoculated, so therefore high-risk exposure. We had a facility that was not UPMC purchase the vaccine for the state to be sent to UPMC to be distributed to those people that were impacted and to Allegheny. So there is that cooperation, and we're getting it on that day-to-day. We're getting there. Preparedness truly is, there's a guy by the name of Dr. Marco Marcosi. He used to work at Asper. He's now at University of Maryland. Marco's a great guy, and he has a talk about preparedness in everyday healthcare, of how our actions during a disaster can help make more efficient our day-to-day operations in the hospital and make us better able to surge those 20% of beds when the time does come. It's pretty progressive, but we're getting there.
I'll just weigh in real quick just to say that what keeps me up at night as I get ready to graduate, the things that start to think in my head is, so if there is a pandemic type of outbreak or some type of influenza outbreak, measles, whatever it might be, or radiological exposure of some type over a large scale area, as the on-duty house officer or administrator, that's my nightmare. You know, that's my nightmare. That's where I go, oh, yeah, because where is everybody going to go? You know, they're going to come to the hospital. They're going to flock to the areas that they know are solid and sound, and so they're going to come to the hospital. And suddenly now I go from being, you know, zero to, you know, like just on cruise control to light speed, and I have to anticipate that and think about that. And it could be, it doesn't even have to be anything as flashy as that. It could be a large fire in your town that you know, evacuates, you know, several hundred people, and then you now suddenly have a disaster in your own little microcosm of a world. So
I think with the Joint Commission being unannounced too, that has, you know, as far as emergency preparedness is one of the standards that they look at. And I think, you know, ongoing, always being on top of things and not just waiting for the survey to come, or, you know, making sure that your paperwork is in line, making sure that you're proactive about keeping things on top of things, as opposed to just kind of being in cruise control and not, you know, just waiting for the 3 years to come by and being re-inspected. But I do want to mention Chip Franklin is one of our graduate students in the master's program, and he is about to graduate, and he will be undertaking an administrative position at some point and be ready to take whatever disaster comes his way,
yeah.
right?
Right, absolutely.
I think, Jason, he volunteered for a chair position of the coalition. I thought I heard that behind the microphone.
In closing, I just want to start with Chip and come down this way. If you can just final thoughts and, you know, very briefly what you're going to be doing to be prepared tomorrow and in the years to come.
I think that some of the more telling stories, and I think that the PowerPoints presented that, were, you know, what do you do when we as healthcare administrators or nurses or what radiation techs or whatever it is that you do within the hospital, how are you going to be prepared for your family? You know, so have that plan in place. My sister is a physical therapist in Myrtle Beach and was evacuated twice last year, and so the concern, of course, is, you know, what does her husband do? He's a high school teacher. He doesn't. You know, he's got the kids, he's gone. So, but where are they going to go? What is and her fear is, you know, her fear has always been, what are you going to do so that you can dedicate your attention to what you need to take care of? Mm-hmm. Because if you can't, then, you know, you become more of a hindrance or a liability than a help.
It's kind of putting your oxygen mask on yourself.
Absolutely,
before
yeah,
you
putting your oxygen mask on
to
before
help somebody else.
Yeah.
Jim.
Yeah, just to dovetail on that, I think outside your normal day-to-day activities. Mark mentioned it. If the power line's cut at a hospital and you have 3 patients on a ventilator, what's your plan from there, right? And if that power line disruption lasts for more than a day, 3 days, 5 days, you know, what's, because of weather or any kind of construction event or whatever the case may be, what's the plan and what's your particular role? So just stressing the importance of getting involved in those preparedness efforts, those planning efforts, so that when you have to escalate to a response effort, you know and you're comfortable with what your role might be, and also think outside of what that role might be to get through that particular incident based upon your planning activities.
Dave.
I think it's, you know, I think one of the things that I do, one of the things I do when I teach emergency preparedness at the hospital is I try to get rid of that idea that it can't happen here. It can't happen to us. So my PowerPoint opens up typically with some pictures of about 12 events over the course of 8 years that we had at St. Clair Hospital. This happened, that happened, and they're scalable. It doesn't have to be the big region-wide nuclear event that happens. It could be those smaller events in the hospital, and that's where the incident command system comes into play because it's scalable. You can use the incident command system every day from something small to something region-wide or nationally. We're all speaking the same things. And the other thing is when the crazy people that do emergency preparedness, like our panel up here, come out and say, we want you to be involved as an employee, please do that. Even if it's as simple as keeping your contact information updated in your emergency notification systems. You know, get involved with your hospital emergency response teams. You know, it's all about you're being able to get integrated and learn about emergency preparedness because the organization, your patients are going to benefit from it. So just some thoughts on my end.
So I think the takeaway comes back to communication, and none of us work in silos. We all work as a team. So if you are a patient, if you interact with the healthcare system, you don't just interact with one person. You work with an entire team, and it takes that entire team to take care of our patients. And the more that we can talk to each other within our organizations, between our organizations, within coalitions, the better prepared we are. Because, like you said, the first time you meet the fire chief is not when the fire is happening. The same thing with the first time I want to meet my counterpart from AHN, who's working at Allegheny General, is not in the middle of a disaster when I'm calling them up and saying, hey, I really need your help on this Ebola patient. And we do communicate across those lines. You know, the organization that I'm involved with, the Pennsylvania College of Emergency Physicians, I work with the folks over at Allegheny General. So I know guys at St. Clair. I know people that I can call up and say, hey, we need help with this. So communicating between everybody, communicating within your organization so that when the time comes for a disaster, you have that team ready. Because nobody's going to be able to take care of any of this by themselves. If a disaster happens, you need everybody to get on board.
I'm going to go back to you, same way that a couple of the panelists did. You're the next generation. I have my AARP card, okay?
At only 29?
Early admission, thank you. You're the next generation, and it comes to you. You need to be prepared to start. You need to be involved. You need to lead. Jason will tell you I have some thoughts that I have blinders on, and sometimes I don't look outside of my blinders because I'm set in my ways. Look at the problems that we face. Come up with a new solution. Get involved. Just because you haven't been doing it for 25 years doesn't mean you don't know the right answer.
And as this whole event is about networking, we can see how important networking is in a disaster situation, networking as a career, making sure that we are all talking to each other. I want to thank the panelists, and if we can give them a round of applause. CEU certificates are on the side table if you want to grab one on your way out. They're unlabeled, so you can put your name on it, and it will provide you with that CEU. But I want to thank everybody for their work. I want to thank Chuck, our audio man back there. I didn't have an opportunity to introduce him, but thank you very much, and we will see you in the fall at our fall networking educational event. Thank you again for coming.
Thanks, everyone.